and welcome back to Health Watch. Today we're going to be talking about some common causes of wrist pain. As our guest, we have an orthopedic surgeon, Dr. Ray Jegan. Welcome to our show.
Thanks, Vince.
You're with Orthopedic Consultants, and you do a lot of work with particularly wrists, I understand. And how did you get interested in that particular aspect of it? I mean, it's a fascinating joint. Tell me about it.
Well, I had a strong interest in hand surgery when I was a resident, and then after I had been in practice for quite a while, I went back and did some subspecialty training, and spent a lot of time working with a hand surgeon in Philadelphia who taught me a lot. So I found the hand and wrist to be quite fascinating, and there's a lot of new developments there.
Yeah, when you think about it, we always talk about the recommendations now and the current advancements in hip replacements and the various joint replacements. You don't kind of think of the wrist as a joint itself, but there's not a lot of room there to do stuff. So, but with current methodologies, I understand you can do a lot more, and I think that's what we're going to be talking about today.
Right.
Show us a little bit about the anatomy. It's a fascinating joint when you think about what you have to do with your wrist.
Well, the wrist joint is quite complex. It's not just a simple ball and socket such as a hip joint. There are the two bones of your forearm, the radius and the ulna, which articulate with 8 different small carpal bones in the wrist. Each of these has a particular movement. They all move synchronously, and they rely on a strong ligamentous support structure in order to make all that work properly. There are actually more than 20 different ligaments connecting all these bones together to provide smooth function. Of course, any of these bones or any of these joints or a combination of ligament and bone injuries can occur that brings patients into the office.
Yeah. I mean, I guess as in every one of us, all our joints, it's subjected to all the traumas that we think about, as well as arthritic changes, and I guess that's part of what we're going to be talking about today.
Yes.
Patients that come to you with wrist pain, I guess it's when you see them in your office, it's certainly different than when you may see them in an emergency room setting where they obviously have done something. What do they usually complain of, and what's your approach as you talk to them and get a good history?
Usually I'll ask them if something happened, find out if there was a particular injury, find out how long they've been having pain, see if it's an acute onset or whether it might have been something that's been progressive over a period of years, find out whether or not there has been a remote history of injury. Once we take the history, then we would do a physical examination, basically look at the wrist, see if there's any deformity, swelling, check the range of motion, see if there's any restriction, see if there's any clicking, popping noises, etc. And then once we examine the patient, we put together a little bit of a group of possible diagnoses. Then usually we would send the patient for an X-ray.
Just to go back to the history a little bit, how much is work history involved in that? And we know we'll probably get into carpal tunnel at some point in this discussion, but I mean, the jackhammer guy and the guy that's persistently using his wrist for a variety of injuries. How does that contribute to this, and does it change your approach?
Well, we certainly see a lot of work-related wrist problems, whether it's a fall or a twisting injury or just a repetitive motion type of injury. They're very common. It depends what the problem is as far as what our treatment recommendations would be. If there's been an acute injury, more likely something is significantly damaged, and we need to find out what that is and see if it's something that will heal or whether it needs a repair. Yeah,
talk to me. We live in a day of computers now, and everybody sits at their desk and working on computers, and wrist injuries from that is not uncommon. You'll see women or men at their desk sitting there with wrist braces, and is that a new injury now that we're looking at? Is it something you're seeing more of?
Well, computers contribute somewhat, although we used to think that a lot of computer work contributed a lot to carpal tunnel syndrome, but we've actually found that that's not a major factor. In fact, there's even a report that indicates that a lot of use of the computer reduces the risk of carpal tunnel syndrome.
Really?
Interestingly enough.
Yeah, because there's been a lot of different devices that have come about as a result of that, trying to limit the angle and the like with wrist injuries.
Right. Certainly you have to have proper setup for ergonomics at your computer to help reduce tendinitis problems and some other sources of pain in the wrist from computer use.
Any particular sports injury that you look at? You're seeing young people particularly.
I think everything probably affects the wrist.
Oh, no particular ones that You know, you think about bowler or something along those lines, and particularly.
I think every sport has its risks and a lot of falls or twisting type maneuvers. So there's I think almost any sport can result in some sort of wrist injury.
Yeah, sure, when you think about it. So you're seeing a patient that doesn't have that particular type of history and they come to you and you're now trying to get up a differential. Is there any particular area of the wrist that they complain about that gives you a better clue than one than the other?
Well, if someone has had an injury, they've fallen, most of the time there's two fairly common fractures that we'll see associated with that. So we could start talking about that. One of the most common injuries is a fracture of the distal radius. Typically that occurs as a result of a fall in the outstretched hand. Patients come down this way and the end of the bone just can crumble many times. There's many fracture patterns. It can be a simple break with just a single fracture line, but most of the time, because the bone there is on the softer side, it results in many bone fragments, which makes it particularly difficult to treat. We used to treat these by basically just numbing up the bone, pushing on it, putting a cast on it, 6 weeks of immobilization, and then we're ready to start using it. And we used to think that the results weren't too bad with that. But when we really looked at it closely, these patients came back with deformity of the wrist. Typically what would happen is the bone would, because it was crumbled, it would gradually shift back out of position. The bone would shorten, it would tilt, and that would change the mechanics of the wrist, which often could result in pain or limited strength or function. So we then started developing other techniques for trying to stabilize the bone besides a cast. Years ago we would put pins into the bone and then wrap a cast around it. Then we went to a device, the external fixator, which is a pair of pins that go into the metacarpal bone here and the radius, and they're connected by a bar which distracts the fracture so that it can help some of those fragments line up better. This is a device that was used quite commonly, is still used somewhat, but not nearly as often. It's effective for some fractures, but many of the fractures now we actually treat with plate and screw fixation. Well, there's been a lot of changes in the designs of the plates. We used to use a plate which basically the screws would just go through the holes in the plate and then they would have to lock into the bone on the other side of the fracture. One of the problems with that is that, well, first of all, the plates were quite large, the screws were large, they had large heads, and the bone that we're putting them in was crushed.
Yeah, particularly in the wrist area.
Right. So really didn't have much to hold on to. So a lot of times we'd end up not getting very good fixation in the first place, and then it continued to sort of fall apart over a period of weeks, and sometimes the hardware then got loose, it would rub, cause problems with tendons and nerves. So we abandoned that until this new technology came out, which is called locking technology, where the screws actually lock into the plate. There's a couple different designs that I have here.
Well, I got to stop you there because we're going to take a break.
Okay.
We'll come back and we'll go into exactly how they work. And we'll be right back after this message.